Hello, my name is Charles Abbottsmith. I'm a semi-retired cardiologist working here in Cincinnati at the Christ Hospital. I was born and raised in Montreal, Canada, and went to McGill University to study science. And near the end of my science program, I realized I wasn't sure what I wanted to do in life. There was one thing I was certain about, is I didn't want to go into business. So I thought medicine might give me more opportunities to find some sort of work that I liked, a lot of possibilities in the medical field. So I continued in medicine at McGill and completed that study. And at the end of it, I went into Montreal General Hospital for a 3-year internal medicine fellowship. At the end of the internal medicine residency, I decided I wanted to go into cardiology. So I wanted to go in to do some cardiology fellowship training.
What was it about cardiology that really interested you the most?
I liked the idea of cardiology being a single organ that I could wrap my mind around, as opposed to internal medicine where you'd have to know everything about everything.
Right.
And it seemed more something I could grapple and handle. Also, I liked the idea of the working with your hands to do cardiac catheterizations, which I was just starting out at Montreal General Hospital. So I did my cardiology fellowship at University of Cincinnati. And at the end of that program, the United States government told me if I wanted to stay in the United States to live, I would have to do a 2-year stint with the U.S. Army first. Or I should go back to Canada and live there.
So you had the choice of either staying in America and going to Vietnam, or in your case,
Yeah.
You went to Japan, correct?
Correct.
Yeah, or go back to Canada.
Correct.
So, and you chose to go to the war, and you practiced medicine there too, right?
Yes, I was chief of cardiology at the Army Hospital in nearby Tokyo. And then after that, came back to work at Christ Hospital in Cincinnati. I liked the idea of practicing cardiology and staying in the United States here because in Montreal, to continue to do cardiology, it took several years to grow into the program, and you'd have to start working in the clinics first of all, and be a lot of grunt work before you could actually do what I wanted to do, which was cardiac catheterizations.
Right.
Whereas at Christ Hospital, right from the get-go, I was doing pacemakers and cardiac catheterizations and all of this fun stuff. And it was sort of like the Wild West, as far as I'm concerned. And I was assistant director for 4 years, and then I became director of cardiology. And I remained director for the next 30 years.
And I understand that you were trained in Switzerland for a special procedure.
Yes.
First amongst any physician in the tri-state area to do this.
That's correct. Up until 1980, we took pictures of the coronary arteries with cardiac catheterization and decided whether the patients needed medicine or cardiac surgery. Those were the only two alternatives. However, in 1977, a fellow in Switzerland, Dr. Andreas Grunzig, devised a sausage-shaped balloon that when deflated and passed into the coronary artery and then inflated, could push the plaque aside and open a blocked artery. This was revolutionary because it allowed us to treat patients who have blocked arteries non-invasively rather than with surgery.
And a blocked artery means that they're having a heart attack?
Yes. So this was a new way of treating. We had always been told, don't go inside the coronary artery, it's dangerous. But Andreas Grunzig showed us that's not true. So I came back from the training and waited for a perfect person to do this on. One came along, it was November 11th, 1980. I'll never forget that date. And we were in the cath lab. There were half a dozen interested physicians also watching to see what was going to happen here.
I can't even imagine how nervous you
Oh,
were.
I was extremely nervous. And I passed the catheter down the coronary artery, and he seemed to be doing okay, and inflated the balloon, quickly deflated it and pulled it back, and took a picture, and the artery was now open. It had had a blockage there, and it was now gone. And I recall thinking as I walked away, I can't believe I didn't kill this guy. So from then on, it's been just a wonderful, wonderful growth and experience of this practice of cardiology. More recently, stents were devised that were made out of polymers that would dissolve completely. And that would leave the artery, after it's been opened and stayed open for a while and healed, it would then dissolve and the artery would remain normal. And that would be the ideal treatment, not having a piece of metal in the heart all for this person's life. And I was fortunate to be the second person to do this in the United States just several years ago. Now I'm doing part-time cardiology office practice.
And you still enjoy it, right?
Oh, I just love it. I love it. It's just very exciting to be able to help people and to be just you and them in the room alone. They tell the story and you listen to them and develop a strong relationship. And it's so meaningful. I mean, it can bring you to tears sometimes, the things that you're able to, how you can help people. And I enjoy it tremendously, yeah.
My name is Mary Mahoney. I am a radiologist. I'm a physician. I am the department chair of the University of Cincinnati Radiology Department. And I am the chief of imaging for UC Health. So 2 different roles, 1 job, 1 person. And the way that works is in medicine, in an academic medical center, as opposed to a community hospital, we have 3 missions. 1 is education, 1 is research, and 1 is our clinical mission. So education means that we're training the next generation of physicians. Medical students, we call them residents, where they're subspecializing, and then fellows, where they're super subspecializing in not just radiology, but in one area of radiology. So we have an educational mission and we have a research mission. Around research, we will tell you that today's research is tomorrow's practice. So what we're doing today that's under the research realm or umbrella is what's going to translate into clinical practice, better methods of taking care of patients in the future. So those are my missions under the college side of what I do. And then under the UC Health side, our clinical mission is to take care of our patients, to do the best high quality patient care with best outcomes. I'm also involved in a number of national boards. So my involvement in radiology has been not only locally in Cincinnati, but I felt very compelled to get involved with what's going on nationally and even honestly internationally and globally with radiology. So I'm on the board of governors for the American Board of Radiology. That's the organization that certifies physicians and says, yes, you're qualified. Yes, your training is adequate. Yes, you are now board certified and can go out and practice. I'm involved with the RSNA, which is the Radiology Society of North America. It's the largest medical meeting. It's a huge society, and it's very internationally, globally oriented. American physicians and the quality of medicine that we practice is just astronomical. It is so incredible and so beyond what many other countries can do. RSNA has a global outreach where we are partnering with physicians across the world to try to improve patient care. So last week I was in Japan. Next week I'm going to Brazil. 2 months ago I was in Vietnam. The year before that I was in China. I go all over the world trying to train physicians to do what I do and to interest them in improving the quality of patient care in their countries. It's enormously rewarding. I'm getting emotional. edit this part out. Wow. Okay, and then I also work with the American College of Radiology because medicine in this country is really complicated. So there's all these issues about reimbursement and what does the government pay for and what does insurance pay for and what should patients, what a proportion should an employer take on as the burden? What is the patient's obligation? Should everybody get everything they want all the time? Do we need to limit resources? Who decides? How do we decide? What do we do? And so the American College of Radiology is more the advocacy, the lobbying, the working with government, working on reimbursement, working on regulations related to insurance. And then locally, just dealing with this huge department. I have 90 radiologists. We cover CT, we cover MR, we cover ultrasound, we do interventional, we do catheterizations, we do nuclear medicine, we do mammography. It's a huge department with hundreds of thousands of patients. It's just a lot. It's a lot. It's really exciting. It's really interesting.
Yeah, that's what everything is.
Yeah, it's a lot.
It's a whirlwind of emotions.
It is. It's a lot of stuff and a lot of work. It's exhausting. It's exciting. It's interesting. It's always interesting. Always interesting. Yeah, I am fortunate to say that's my life because I'm not sure everybody else in the world would tell you that they have an exciting, interesting, awesome, incredibly great job. And some people would say, no, life is dull. Life is drudgery. And I don't say that.